Let's go ahead and get started with our next session for the plenary session. Our next speaker is Dr. Andrew Keller. He is CEO of the Meadows Mental Health Policy Institute and a psychologist with more than 20 years of experience in behavioral health policy. He is a recognized leader in health and human services integration, behavioral health financing, and implementation of empirically supported practices for adults and children. He is also a founding partner of Tri-West Group, a national behavioral health systems consulting firm focused on human service evaluation, community collaboration, and management. His work has centered on helping local systems implement evidence-based and innovative care, as well as helping local and state governments develop the regulatory and financial framework to support them. Please join me in welcoming Dr. Keller.
Well, good afternoon, everybody. I'm going to actually get with Justice Boyce next time and have him help me edit my bio because I think it could be a little bit more streamlined. Appreciate folks being here today. And so I'm looking out in the audience, and actually I'm going to see if I can get to my next slide. Okay. So this is my title slide, and I'm looking out there, and I think that many of you maybe are guilty of the same thing that my grandfather, who made it through 8th grade, accused me of. Now, I grew up, I'm a got here as soon as you can Texan. That's my role here, and I love being here, happy to be here. But I grew up in Eastern Washington on an apple farm. And so I kept going to school, and my grandpa would come up to me, and he accused me of going to school for too long. That was my thing. So I look out there, I think a lot of you are in the same boat. You maybe went to school for too long, especially in the words of my grandpa, especially if, like me, you weren't becoming either a lawyer or a real doctor. Now, many of you did become lawyers, and some of you, like Octavio, became real doctors, so you probably would have made my grandpa proud, but I was quite perplexing to him since I became a psychologist. But one thing you learn when you go to school for too long is that learning is actually secondary to getting good grades. And I look out here and I see that many of you have that same belief. I'm guessing. You got good grades, you got to where you are. And so I want to tell you how to get an A on this section of the presentation. It's all right here in the title, okay? So the first thing is you'll notice that I say the system is broken. See that? And I put it in quotation marks. What does that mean when you put things in quotation marks? It means it's not true. Now, why do I tell you the system is broken and it's not true? I'm going to tell you why. I'm going to tell you the punchline right now, so if you quit listening, you've got it. The reason is it never, ever did work. In order for something to be broken, it has to be dropped and work, okay? So what we're doing here, I don't want you all to feel bad. I want you to feel sorry. I want you to feel moved to help people, but I don't want you to feel bad or guilty for having a broken system, because you didn't break it. Nobody broke it. We're building it together. And this meeting today and the leadership of Chief Justice Hecht, all the people who brought this together, Presiding Judge Keller, this is a huge step forward. So you're part of building something new. The second thing is the secret to building something new is to remember that mental health is health. It's a health care condition. It's a set of illnesses that healthcare systems can treat. So when I say creating integrated adult and children's mental health systems, the integrated part, one day it would be nice to not say that, because we only say integrated because we need you to begin to treat these things like health conditions. So if all you remember leaving today is the system's not broken, you're building it, and two, the way to build it is to build health systems to do what right now we rely on the jails on, you're done. So you can leave now if you'd like. But we also have extra time, and I'm going to try during the talk today to have people maybe jump in and ask some questions. If you do ask some questions or have some comments you want to make as we go through this, we're going to try to have somebody come and give you a microphone. But if you're too far away from the microphone, we're not going to wait. There's a microphone here. But the other thing we could do is if you just don't want to walk to the microphone, I'll repeat your question for folks. Okay, now, do people know why we say the system is broken? Does anybody want to guess? I'm not going to make you guess. It's because it feels broken. You know, when we have someone in front of us whose life is broken, whose life is in shatters, whose, we see so much tragedy. We hear what Dr. Nettie gave a fantastic overview, but it's a little overwhelming, right? You hear about all these illnesses, and I'm really glad she talked about the specific illnesses because there's really no such thing as mental illness, no any more than there's physical illness. I mean, we don't treat physical illness, we treat cancer, and we treat heart disease, and we treat schizophrenia and depression, other physical illnesses. So Dr. Natty's overview was fantastic, but I think it was a little overwhelming, and I'm sure many of you feel overwhelming, and that's why we often say the system is broken. Our job at the Meadows Mental Health Policy Institute is to be one of many organizations out there to help you as decision makers in Texas, many of you in the justice system, many of you in the mental health systems, to try to figure out how do we do a better job. And that's our mission at the Meadows Mental Health Policy Institute. It's to help Texas have the best mental health care anywhere so that people get mental health care where they need it, when they need it, and they get the care they need. Because people need different kinds of care for different conditions, which I know is a shocking statement, but it is actually true. So that's our job. There's a lot of other people out there. My colleague, Dr. Octavio Martinez from the Hogg Foundation, that's our sponsor for lunch today, has been leading for decades. He hasn't because he's such a young man, but the Hogg Foundation has been leading for decades in the area of mental health, and they have a much broader focus on health equity, lots of other things. Our focus at the Institute is on helping build more effective health care delivery systems. And there's lots of other folks out there because the way we work at the Institute is we focus on state policy, and we work a lot in Austin, but we look at that intersection between state policy and local systems because a lot of the things that get in your way locally are really state laws or state funding rules or other things that make it hard for you to do what you need to do locally. But it's not all the state's fault. There's also things we need to do a better job at locally, and there's lots of partners out there, and I see many of those folks here in the room today, folks like from the Texas Council Community Centers, folks from the Texas Hospital Association, folks from the Texas Alliance for Child and Family Services. There's lots of partners out there who can help you, and there's a dozen more I'm not naming yet, but those partnerships are essential, and I love what Justice Guzman said, that collaboration is the key, and that's what we need to do to build this system together. So let's talk a little bit about some terms just to review. And Dr. Natty went over these, but I'm going to use these a lot, and it never hurts to hear things a couple times. So mental illness, she talked about, is something that involves thinking, emotion, or behavior, but you also have to have distress or problems. So just because you have emotion or problematic behaviors, if it doesn't functionally impact your life, it's not an illness. The flip side of that is mental health. And a lot of times we talk about mental health when we actually mean mental illness. And I think it's important for us to have a concept of mental health that's out there too. It's something that we all try to get to, and that's psychological or emotional or social well-being. So keep that in mind. There's this continuum between health and illness, just like there is for everything else. I mean, think about your hearts. There's a continuum between being fit and being able to run a marathon and between having a heart attack, and there's a bunch of things in between. We talked a lot this morning about some of the more severe mental illnesses, but I want folks to remember that like any illness, these illnesses are on a continuum that ranges from mild, early things like, you may have a little wart on your hand. That doesn't look like a problem. You may have a little mole on your hand. That doesn't look like a problem. You may find out when you go to the doctor it's actually a big problem. It's cancer, and it's something you need to do about when it looks like a little mole as opposed to when it's something that's metastasized throughout your body. So that continuum is important. Intellectual and developmental disorders are important. And remember that those disorders always begin before the age of 18, but almost always begin at birth. In those first few years, they become manifest. So we need to remember that these are things that we need to be looking at not when someone comes into the justice system, but before people come into school, if we really want to help people with them. And then this Texas Statewide Behavioral Health Strategic Plan is a really important document. If you haven't heard about it, this is something really cool that the Sunset Commission helped push. Senator Nelson, Jane Nelson from Flower Mound, championed 2 sessions ago to form a council that's headed by Associate Commissioner Sonia Gaines, who is the commissioner who oversees IDD and behavioral health services for our state, who's a fantastic resource, her staff there in her office. And then she has a council of all of the state agencies that fund and deliver mental health or substance abuse or IDD services that come together and meet, and they put together a behavioral health strategic plan. It's a resource you should look at because it's a way to keep all of us moving in the same direction as we try to use precious and valuable state resources. They define mental health, behavioral health in that document. They define serious mental illness and severe emotional disorders. And they also talk about the importance of co-occurring disorders, which Dr. Natty gave an excellent overview on. And I think her point about the ubiquity of substance use disorders, both as problems of their own, like you don't need to have a mental illness for an opioid addiction to be a life-changing or life-ending condition for you. And many people who have opioid addictions do not have mental illness. They have an opioid addiction. Young man can blow out his knee playing football, get put on an opioid, and he can, if he's given too much of that, develop, or just if he has the wrong predilection, develop an opioid addiction. So it's not always that these come from mental illness, but particularly among the folks y'all are going to see in your courts, folks who repeatedly come through on the adult side who've had mental illness for years, rates for the folks who are using our systems a lot are as high as 85% in Judge Emmett's Senate Bill 1185 diversion program that was developed 3 sessions back here in Houston and is now became the foundation of the SB 292 program, which does that around the entire state. 85% of those folks had co-occurring substance use and mental health disorders. So it's something that really ranges, and the sooner we intervene, the better. And I want to talk about that because mental health conditions progress. And a lot of times we do not see people until they are homeless, until they are impoverished, until they do something which brings them to the attention of civil authorities, whether they be in an emergency room or a law enforcement officer or a judge. That is not where they begin. No one goes from functioning one day to being homeless and impoverished and psychotic the next day. That's not how it works, folks, just like any other illness. By the age of 14, 50% of every mental illness is present, including some of these more severe illnesses, which guess what they look like when you're under 14? They look like anxiety. They look like the kind of things that get in any child's way. And Dr. Natty was exactly right, that just because a person has anxiety, just because a person has distress, doesn't mean they have a mental illness. But if they have anxiety that gets in the way of social functioning, that gets in the way of school functioning, it's something we need to worry about then when it's a little mole that we're beginning to worry about, as opposed to wait until, on average, what the American Pediatric Association tells us is we wait 8 years on average. And you know how long we wait for psychosis? 7 years. Okay, so that's why things get worse. We also know that by young adulthood, that's me, 75% of lifetime cases have presented. So I interacted with my mom over the weekend. I said, send me some pictures because I need to illustrate what mental illness looks like over the lifespan. So mom sent me, and you know what, I do have mental illness. I suffer from a pretty, actually significant anxiety disorder. Now, I don't act like that usually when I'm talking. I did act like that when we had that joint hearing of the Supreme Court and the Court of Appeals, because, you know, they say, hear ye, and I had to stand up. I'd never done that before I gave a talk. And then I got up there, and they're all wearing the black robes. Thank you for not wearing your black robes today. But that was very anxiety-producing. I flashed back to what things were like. So this is little Andy, I think at my baptism with Mom and Dad Keller out there in Washington State. We had churches as well as farms. And so I'm pretty happy there. But my mom wrote in my baby book when I was about 3 that I said, I am so anxious because I was waiting for something, which she was very proud that I used the word anxious when I was 3. But she didn't focus on the fact that I was pretty anxious when I was a little kid. I didn't like going outside. I didn't like doing a lot of stuff. So by the time I became this guy, age 18, which, by the way, remember what we talked about in terms of social conventions? Wearing an ascot and a gray suit was actually a good thing in 1984. This was not a sign of social dysfunction. Doing this today, you might have questions because violating social norms is something we do when we have a mental illness. But this guy, he looks pretty happy. I mean, look at that curly hair. Yeah, I did have a permanent back then. That's something we also did in the early 80s because you wanted your hair to feather nicely. So I was pretty proud of how I was looking that day, but that's a pretty anxious kid. You know, when that kid got to college and for the very first time in his life actually had some hard classes because they didn't have very hard classes in my rural high school, you know, I'd sit in my room. Wouldn't leave. I'd grab my knees, I'd rock, I ate a lot of meals in my room. Those are not functional behaviors, folks. That's a pretty high degree of anxiety. And it's not something I was able to get treated until I was well into my late 20s when I got into graduate school, became a psychologist, and talked to, because one thing you want to do if you become a psychologist is you do need to figure out what your own issues are. So we worked on that, and that was good. And I got to the point where when I was ordering a bagel, I could actually tell the person that I'd rather have that bagel instead of the one that they grabbed without fearing that they would upset me. Now, this is important to keep in mind because Dr. Natty pointed out to you that mental illness is not a major driver of violence. And, you know, that's something that our society has a hard time with because when we see these horrible events happen, we look to mental illness as the driver. The reason is different mental illnesses have different correlations with violence. So if you have anxiety disorder like me, not only are you less likely to tell the person that you actually want the other bagel and not the one they grabbed, you're also less likely to murder that person or to hurt that person because you're such a worried person. You may blow up in the 10 item or less line if somebody has 12 items. You may confront them and be really anxious about that, but you're not probably going to hurt them. But if you have a different mental illness which, by the way, occurs at the same time. Between ages 15 and 25, psychosis strikes. Psychosis is sort of those initial signs that something really serious is going on, a delusion, a psychosis, something like that. Same age, folks. If that struck and I was not treated, I would have almost 15 times the risk of murdering somebody as somebody who didn't have a psychosis, and most importantly, as somebody who had a treated psychosis. Treatment, getting someone in treatment eliminates that risk, brings it down to the same risk as the general population. We know how to treat mental illness. Do we know how to treat every mental illness? Nope. But we know how to treat most of them, far better, I would say, than some other disorders. So look at this guy, 49-year-old Andy Keller, feeling pretty good, feeling like, much less anxious. Takes fish oil every day. Fish oil is awesome if you get the good stuff. I'm 49 years old. If I had, however, instead of having an anxiety disorder when I was 18, if I had had a psychosis and I had gone 7 years before I got any effective treatment, I would have died at that age. Because that's the average age that adults with serious mental illness die in Texas, not from suicide generally, though sometimes, generally from comorbid health conditions that come from not taking care of yourself because you have a psychosis. It's hard to take care of yourself when you have an untreated psychosis and you're impoverished and you live on the street or you are not connected to people and you don't work. Your health outcomes are poor. So what do we do about that? Well, here's the bottom line, folks. You do the same thing you do for any other illness. So let's talk about another illness. Let's talk about cancer. So my mom, this is a good story, happy ending, got cancer 7 years ago. My mom had cancer, a life-threatening condition. As it turns out, it was a super aggressive, fast-growing cancer that if she got it 5 years before they had the medication she used, she would have died in less than a year. So where did she go? Where did she turn out? Because that's a serious disorder. Did the police come to our house? No. Did we take her to an emergency room because she had cancer? Nope. She was home and she had her hand on her breast doing the annual, which by the way, to get my mom, who's a very conservative Protestant Christian woman, to touch her breast once a month to detect whether or not she had cancer, folks, you can overcome stigma. You can overcome stigma. Not only did she find that cancer, she went and told her doctor, and she told her primary care doctor. See the little red circle there? Primary care. And the primary care doctor said, yep, you got cancer. So what did the primary care doctor do? Did they call the police? Did they say, go to an emergency room, check yourself in the hospital, you got this really bad disease? Or did they give her what we often do with mental health, is we give them, well, go see if you can find somebody in your network book. I'm sure you can find somebody in your network book. No, they actually got her to specialty care. They actually said, go see this oncologist, and they coordinated back and forth. You know why? Because cancer is a big deal. That's why. So my mom, she had surgery, she had chemo, she had radiation, she got better. Did she ever go in a hospital? Nope, never went in a hospital. Because with cancer, we've learned that you don't have to go in a hospital to have intensive treatment. Intensive treatment just has to be in the least restrictive setting because hospitals are not good places to be. Now, my friend who's my age, who also had a happy ending, who ended up having stage 4 colon cancer, when he went to his primary care doctor, he did get to go to the hospital, because you do go to the hospital if you have to have your colon removed, because that's something you can die from. So we go to hospitals when we can die. We go to other places, specialty places, to get intensive treatment, and that's how we've organized things for cancer. And here's the thing, folks. It hasn't always been that way. Anybody ever watch The Crown? You all look like there might be some people who watch The Crown out there. For those of you who haven't, I'm going to spoil the last half of episode 1 for you. The king had cancer. And the king dies from cancer. And you know when they told the king he had cancer because they didn't want to depress him and make him feel horrible? About 5 weeks after they removed his lung. Okay? They took the lung out for cancer, didn't tell him what it was because they didn't want to scare him. They told him 5 weeks later, because there used to be a big stigma on cancer. I see some of you have hair like mine. You remember that when Betty Ford came out in the mid-'70s and told people she had breast cancer, that was a big deal because we didn't talk about cancer. And when my grandma died of cancer in 1986, you know where they diagnosed her? They diagnosed her because she was in a hospital visiting a friend. She fell, broke her hip, took an x-ray and said, oh my gosh, your body is riddled with cancer. Because folks, that's how we treated cancer 30 years ago. We didn't treat it until you were super sick. My grandma didn't go for preventive screens. Not only did she not touch her breast once a month, and tell people about it, she also did not go to the doctor for any type of preventative care, because that's not how we thought. These are exactly the same things we need to begin to do, and they're things that you all in the judiciary can help us begin to do. Because unfortunately, on our side of the equation, on the mental health side, we often don't see people until we're making a choice between inpatient care and jail. That's often the thing, and we say, well, we need more beds. And we do need more beds. We're building state hospitals. But folks, here's something I gotta tell you. If you're feeling excited about getting someone into a psychiatric bed, Good for you. It's better than a jail. But that was first realized in the mid-1800s by a woman named Dorothea Dix. So don't be too much thinking that you're getting them contemporary treatment. Hospitals are a place to go to not die, to get stabilized, and to get on medications. They are not places to get better. We don't do that anymore. Sending them out to the country to stay in a hospital. That was 1855 model. And so when we built our state hospitals in the 1860s, 70s, through the early part of this last century, we were on the cutting edge. Building more hospitals is something we have to do because we have people in desperate situations, but it is not the treatment people need, okay? And you are in a position in your court to wonder in your community, why are we doing this? Why is it just a question between jail and inpatient care? And I'm also here to tell you that some people with mental illness need to be in jail, just like some people with cancer need to be in jail. People can do bad things that require them to be in jail and have a mental illness. So when we get up here and we're telling you, hey, we need more mental health treatment, don't think that we're telling you we're going to empty your jails. We're not. We're not also telling you you're not going to need to spend maybe not $50 million, but you're going to need to spend $10 million, $20 million in your local jail here because people have mental illnesses. They have other illnesses. We spend money on healthcare services in jail. But at least 1 out of 10 people in our jails right now are there solely because of a mental illness. Because here's how it works. In Dallas County where I live, if you go out on your lawn naked and you make a lot of noise, you will get arrested because that is illegal. But you're doing that if you have a psychosis because of some delusion or some mania or something else that is pushing you to do that. And the right answer for that is not arrest in jail. And we're going to talk about that actually now. Because we have a lot of people in our jails right now in a crisis that I think you all are in the middle of, I know you are, around forensic commitment. We have people who are not competent to stand trial, and because of the work of many of the folks in this room over the last couple decades, we now recognize that right. People wonder, why weren't there forensic commitment waiting lists before the mid-2000s? Well, because we didn't pay attention to this. We didn't help people. We process people through. Are there maybe more people in jail today with mental illness than there were back then? Maybe, but there were a whole bunch of them back then. They've been there for a long time. We of us with mental illness have been there for a long time. But the numbers have begun to go up in the last few years because we are increasingly wanting these rights to be respected, for the person to be competent, and we want the person to get better, and we don't have enough capacity for that in our hospitals. And here's the thing, folks. What would you do if somebody was in your court system and they had a stroke? They had a stroke, they're in the jail. Would you focus on their competency to stand trial? Because if they're not able to talk, they're not competent to stand trial. Would that be what you worried most about? Or would you worry most about getting the medical care to stabilize and ameliorate their stroke? That's where we need to go. Our competency laws are great, but we need to separate this idea that the competency is the way to treat mental illness. It is not. It is the default way that people end up getting treatment because we don't get them treatment sooner, and we actually need to change some of our laws so we can actually maybe get people psychiatric stabilization first before we worry about whether they're competent to stand trial. We need to think of those as two separate things because competency restoration, the education people need, we generally know, folks tell me, in an hour if somebody can get better. I mean, if they have just a psychosis and they get better, they're going to get better and they're going to be competent. Or if they have a severe intellectual disability or some other thing that impedes their ability to learn or represent themselves, I don't care how many days you have in a hospital, that's not going to change. You will maybe be able to figure out a plan for them, but competency itself is something we can do in an outpatient setting. It's not something that requires a hospital. I'm sure people have questions about that. Oh, thank you. Okay. But let's talk about what we can do instead. This is called the sequential intercept model. Anybody ever heard of the sequential intercept model? Yay! Okay, you guys are going to get better grades. The rest of you are still going to get the same grade because you just heard about it, right? You can put it on the test now. You know about sequential intercept model. You can go to your national justice conferences and you could say, yeah, we're doing the sequential intercept model in Texas. And you're going to be one of the coolest judges at those national conferences. Totally cool. There's 5 points where we have to do different things when people have mental illness. The first point is law enforcement. We do different things at law enforcement if someone has a mental illness or not. We train, I would argue, we probably train more of our law enforcement officers in Texas in crisis intervention training, CIT, than any other state. We've been doing it for a long time, and we have some of the best prepared law enforcement officers in the country to know how to differentiate mental illness from other types of conditions that may impede somebody's functioning in the civil setting. So law enforcement's important. What we do when people get there and we do assessments and we try to figure out what's going on is important. What we do in the jails, and we're going to hear a lot about this with the next speaker, about some wonderful things you can do through specialty courts. And then we also have to think when people leave jail, where do they go? Because we don't want this just to be a cycle. And finally, we need to have ongoing care in the community that provides both forensically focused interventions like outpatient competency restoration, as well as intensive interventions like assertive community treatment to keep people in the community so they're not coming back and forth into your jail. Assertive community treatment is an interesting model. It's one that was first originated in 1970. 71 actually, in Wisconsin. So it's not exactly a new model, folks. It's something we've been providing here in Texas for decades, and Texas provides about 1 in 7 of the people who need assertive community treatment with that treatment. But you know who else only provides about 1 in 7? New York. There's a lot of states that don't do a good job. In fact, we've looked around the country. There's only one jurisdiction we found that provides assertive community treatment at the levels that you would expect it to be epidemiologically, and that's Denver, Colorado, and that's because they had a bunch of lawsuits. So there's a whole bunch of ways to think about this. There's a lot of models. I'm not going to get into all these details, but just know that there's people around the state who can help you think through the sequential intercept model. And notice I snuck in something there. Those of you who have really good eyesight can see that on the far left, there's something called Intercept 0. What is Intercept 0? Intercept 0 is effective care in the community that keeps the person from coming into the justice system. And while we're going to spend a lot of time later this morning talking about specialty courts, the best thing you can do is never get those folks in a court. And there's one thing that makes it hard for you. Thank you. One thing that makes it hard for y'all is that Texas is the only state in the country, because I think Wisconsin just changed their laws, where the only people authorized to detain someone in a psychiatric emergency other than y'all as judges are law enforcement officers. So that means anybody with a psychiatric emergency will have interaction with the justice system, because that's the only way statutorily that we will allow that. Now, Governor Abbott, 2 sessions back, vetoed a bill that would have given a small amount of, that passed both chambers, a small amount of authority to emergency room doctors to detain people for 2 hours. There were actually some legitimate concerns about that. One of the ones that I thought was most concerning was that that's really not enough. I mean, we really do need to empower our healthcare professionals more. I'm licensed as a psychologist in Michigan and in Colorado, and I could detain you. I could sign those orders. And you know, no one really wants to do that. There's not a lot of us sitting around saying, well, we really like to detain people. I've threatened it before at parties, but I was just kind of kidding. But the other concern, and I think this is one that I think people get mixed up, and it was something Governor Abbott really said in the proclamation, and I think it's important to keep in mind, is we're not talking about physically detaining people. We don't want psychologists tackling people and putting handcuffs on them. We want law enforcement officers to do that. But the reality is a lot of the people who need involuntary care are in healthcare settings. They're already in a hospital. So it's not the best idea in the world to have a law enforcement officer, particularly in a rural county, travel hundreds of miles to come in, or 50 miles or whatever it is, to sign off on what a doctor already knows needs to be done. So, you know, operationalizing that's kind of tricky. So if we look at, let's take one example, Dallas County. This is Dallas County in 2016. The green, the star in the middle is the jail. That's the main detention center in the county. The 3 sort of green little squares are the 3 psychiatric hospitals that were taking publicly funded folks for care back in 2016. The red dots are the 25 conveniently placed detention drop-off spots for the jail. So do the math. You're a law enforcement officer. You got 2 hours left on your shift. You got to drive somewhere. Where are you going to go? You're going to go to a red dot. But you know, we talked to over 400 of those folks as part of our planning. You know why they were more likely to go to a red dot? It wasn't always because of convenience. It was sometimes. But the other big reason was a humanitarian desire to have that person off the street, because they know that Parkland Hospital actually provides pretty good health care in the Dallas County Jail. And if somebody goes to Dallas County Jail and they have a mental illness, on average, they're going to be there 21.3 days. And if someone went to the main psychiatric drop-off place, they were going to be out in 24 to 48 hours, because guess what? That's all it takes to stabilize most psychiatric disorders. But if you just put them out on the street, you're not actually helping them, because they're just going to become unstabilized another week later. And so the police didn't want to see that person back on the street. They didn't have the aftercare like any other, like the same as any other Texas city or most cities nationally. And so they were doing something humane. Well, what we looked at as a result of that was the 911 system. By the way, one of the things that annoys me the most is bad mental health policy. And I apologize if you disagree with this. I'm sure some people in the room do. But there was a lot of excitement earlier this year when the House said, we're going to get a new number for people to call if they have a psychiatric emergency, a 311 number to call if they have suicide. And it's like, why can't we use the other 3-digit number that we use for every other health condition? Why do we need a separate but equal health system for mental illness as opposed to just calling 911? Because the 911 system is set up, folks, to deal with medical emergencies. And in other states that don't have the laws we do, paramedics respond. They're generally the first line of response, and they bring in police if there's a sense of a risk. And sure, there's always police backup, just like there is when you go fight a fire in a neighborhood where there might be a higher risk of violence. There's always police backup to fire and rescue. But we have it reversed in the mental health system. We have paramedics back up the police. And we actually we were able to change the law last session thanks to Senator West and Representative Price in the House, who changed a law that allows now law enforcement to hand the person over to a paramedic and let that person transport them in an emergency detention to the to the hospital. That's exciting, folks. That's a big thing. And even though that's not a sexy sort of policy change, it's an important one because if the requirement is the police can only hand them off to an emergency room doc, guess how long the police are going to be there? On average in Dallas, we were having 5 officers go out and spending over 70 minutes, the 5 of them, working on an emergency response. So what did we do? We worked with Parkland Hospital and Dallas Fire and Rescue to put together something called the Right Care Team, which sends out a paramedic, a social worker from Parkland, and a law enforcement officer to respond. This has been used in other parts of the country, and guess what they've done in their first 6 months of operations? They've seen almost 900 folks. Almost 400 of them, they were able the next day to do follow-up to check on them because it's that sort of community paramedic model. But there were only 40 arrests, folks, only 40 arrests. And 24 of those folks had previous warrants. Those are the folks, by the way, we want to arrest. There's a warrant out for their arrest. We do need to arrest some people. So 40 folks got arrested. 453 were linked to care, and only 59 of those went to a hospital. The beautiful thing here is if we do these things the right way, we don't have to send people to jail and we don't have to send them to a hospital, but we got to send them somewhere, and we have to have intensive treatment in the community that doesn't just stabilize the symptoms today, but helps that person recover. And on average, if we don't intervene until you have a really severe mental illness and you're in that sort of cycling place, it takes about 2.5 years to get you to a stable enough place where you can be in outpatient treatment. And in the vast majority of cases, it works. More than most cancers, folks. If anybody tells you we don't know how to treat mental illness, they are either ignorant or lying. Probably they're scared because they're afraid that if they tell you too much, that if they can treat mental illness, they're afraid your court's going to overwhelm them because we don't have enough capacity. That's true. So now that's Dallas. Unfortunately, what works in Dallas doesn't necessarily work everywhere. We got a few other counties. We got to figure out what to do, and Dallas is still figuring this out because they only do it in one part of Dallas. So there's a lot of need out there, but that's what's so exciting. You're going to have a chance over today and tomorrow to meet with folks from your community, talk. Some of you are going to stick around for Engage and Excel, which is our annual conference where you're going to be able to interact with people who care about mental health and substance use disorders from other parts of the state, from your region, and we can work on these things. Because these are things, like I said earlier, remember what the test is? System's not broken, we got to build it. Those are the folks you're going to build it with, and we can. So let me stop for a sec. We've thrown a lot at you here about what the drivers are, and you all are living this every day. And I really do kind of want some other thoughts. I mean, and I think in particular, if you agree with this, then just keep sitting there and smiling and looking pretty. But if you have questions or concerns about this or something doesn't make sense, I bet you there's 4 or 5 other people here that it doesn't make sense about either. So, or you can make something up, pretend like you're one of those people to which it doesn't make sense and ask a question. But does anybody have a question or a point about this or something that worries you as I'm telling you about this stuff? Yes, ma'am. So the question is, what resources are still needed to make that beautiful model work? And this is the hard part, right? Lots of resources. We already spend lots of resources. Counties and local governments are spending almost $2 billion a year on emergency room care for substance use disorders, mental health disorders, and jail time. So there are absolutely resources out there that we could be using better, but I'm here to tell you that's not enough. because it actually is cheaper on any given day to put someone in a jail than it is to put them in a hospital bed or to give them treatment. That's why. There are economic drivers of this. We designed the system that way and it's cheaper. And if anyone tells you we're going to save enough money by reducing jail days that cost maybe $90, $100 a day to pay for care that costs maybe assertive community treatment only costs about $35 a day, but you got to do it for 2.5 years. So that's why it's so expensive, right? So we're going to talk about that. I'm going to actually talk about some ways to finance it, but we're going to have to spend smarter and also spend more. And I'll tell you that statewide behavioral health strategic plan was an important first step because you know what we discovered when we did that? We discovered that we were actually spending $3 billion more a biennium on mental health than we thought we were because we counted for the first time the Medicaid dollars. And guess what? A lot of those Medicaid dollars are for adults. We think that in Texas, we don't treat adults with Medicaid. We do, folks. You got to be really sick and really poor. But a lot of people are really sick and really poor. And so we spend a lot of money. If we don't coordinate that service and we don't make those things available, then we're really not using the resources we have. And there's also some cool things that have come up. Senate Bill 292 last session puts about $35 million a year if you count the $10 million that goes to Harris County and the $25 that goes to the rest of the state to fund diversion. There's 31 counties now that have SB 292 programs in them. If you have one, that's a great resource. It's a national model to be spending this much. Resources are real. But, I think it's not just resources because you've got to figure out how to do it the right way. And I think coming together in collaboration like this forum represents as an important one. But you're right. We have to do more things. Is that responsive to your question? Thank you for that. One more? Yes, ma'am. Yeah. So the question was, and tell me if I get this right, nod or shake your head, depending. The question was, so when we look, let's go back to that slide a minute ago, showing this tremendous escalation of the people waiting for services. What are the costs of that? And there has been a lot of look at the cost of that. One thing you all can do locally, especially if you're a DA or you know the DA, is you can think very carefully about what charges you bring. Because see the dark blue line that says 416? Those are people that have to go to a max security center. And max security does not mean Hannibal Lecter, okay? And I think I say that on purpose because I think people hear max security, they know that they got to go to a facility with barbed wire around it and people are scared. You go talk to the folks, you do interviews, the psychotic and other disorders folks have in that category are indistinguishable from the routine psychiatric conditions being treated in hospitals in every one of your communities every day for many of those individuals. What's not the same is they got charged with one of 10 charges that automatically means you can only be assessed in a high security setting. And one of those is domestic violence, and it should be. Domestic violence is a very severe thing that poses tremendous risk. But one gentleman who died in one of our jails last year was waiting on a domestic violence charge because when he was being arrested, he pushed a family member who fell down and injured her arm, and that was the domestic violence charge, which meant that person couldn't just go to a regular civil bed. They had to wait for one of our very limited, very few max security beds. And that's dumb, folks. So if you're charging, and there are counties out there where you are charging 4 or 5 times the same rate that other counties are. Look at Harris County for a benchmark. If you want to know how your county is doing, get the numbers. They're actually kind of hard to get, but you can get them about what your forensic wait list is. And you can see on a per capita basis how you're doing. And there are big counties out there, folks, that have 3 or 4 times the same number of people per capita charged with these offenses. So be thinking about what you're charging folks, and you're going to have, I think, just being able to access other resources. And there's other analyses we can get into, but that's an important one. Let's do one more. The woman back there in the turquoise, or light green, or lovely sweater. Yes, ma'am. Thank you for saying that. Recovery, folks. Ma'am, thank you for sharing that, because recovery is not only possible, most people recover. There have been 7 international studies of people with schizophrenia, with the most severe disorder, that look over a 20-year period. Do you know what percentage of them are no longer diagnosable with schizophrenia after 20 years? 2/3. And this is with 1960s and 1970s era treatment. You get better. It may take a long time, but you get better. The other third are dead, or in a horrible situation, or are among the very small group of people who we don't know how to treat their psychosis. There are people in our state psychiatric facilities whose psychosis we don't know how to touch. But that is extremely small. I would say probably better than most cancers. In fact, let me segue to that. So remember, I don't like talking about mental illness. I like talking about specific mental illnesses. So this is a layout, and by the way, I think we're going to get these slides to folks later. So if you could take a picture, but we'll also get them to you eventually. And if we don't, email me at the Institute and we'll send them. But we got 20 million adults in Texas, and in any given year, about a quarter of them, just under 5 million, and this is 2016, are going to have a mental illness. Well, 3.85 million of them, folks, don't have a severe mental illness. They have my mental illness. They have anxiety that can be treated very readily by a primary care doc. They have depression that maybe it's complex, so they need to go see a psychiatrist, but it's very treatable. It doesn't lead to poverty. And the social determinants that the woman who just spoke talked about are huge. If my child has depression, I have a lot of resources to keep him in school, to keep him clothed, but I'm fortunate. If I was incarcerated and my wife was working an extra job and she couldn't take time off because she's an hourly worker, she doesn't have leave to go do that, how's she going to go through the brain damage, if I may use that term, to get him, and it probably does damage her brain, to get him the treatment he needs when it's so hard to find a psychiatrist? So those sorts of social determinants, we're all equal, or most of us are equal. We found some differences. Poverty does actually increase your exposure to adverse childhood experiences, but it's pretty ubiquitous. Adverse childhood experiences, which is not ubiquitous, are the resources to do something about it. That's what we don't have, folks. So the other thing we do is we wait. So there's a bunch of people with severe mental illness, about just under 1 million. There's just over 500,000 of those folks are in poverty. The only reason the others aren't is because either they've recovered, many have, and many of them do have jobs, and are productive. Some of them have bipolar disorder, which is a severe mental illness, and they're working. There are probably people in this room who are very successful in their careers who are managing a bipolar disorder. I know there's at least 15% of the people in this room who have depression who are managing that very well and doing a great job with that. But there's about 10,000 folks in the state, and another 8,000 with a lot of forensic involvement who are cycling through our emergency rooms on a regular basis. And these are the folks that we waited too long to serve, or we don't know how to serve, a few of them we don't know how to serve, whose illnesses have metastasized into all those other parts of life. By the way, did you see that good-looking guy in the ascot I showed you earlier? If he had gotten a psychosis and his development had been frozen at age 18, he didn't know how to cook when he was age 18. He could make a peanut butter and jelly sandwich, but that was all he could do. He certainly had never seen the inside of a washing machine. That was something his stay-at-home mom did for him, and she was a loving mom. He didn't know anything about balancing a checkbook. He didn't know anything, certainly knew nothing about meeting women or having social interactions. I think I was asked out by somebody to go to the prom, if I don't remember correctly. If I had been frozen there, my ability to function as an adult, which is what happens when you have a psychosis. The psychosis is one thing, but it's the freezing of your development. So you lack social connectedness, you lack jobs, you lack employment. That's what gets the person more likely into your court than the psychosis. If the person is managing their psychosis or their delusions with medication and they have good social support, there's a very good chance you're never going to see them in your court because they're helped. And what we want to focus on, folks, are the 2,000 people every year who have what we call a first episode of psychosis. Because here's the radical thing we discovered 3 years ago. This is really complex, so pay close attention. If you do the same kind of intensive interventions that we do when somebody's going in and out of jail with somebody in the first year when they first develop the psychosis, they get better faster. Isn't that shocking? If you do intensive treatment 7 years earlier, they get better faster. Why? Because they're not poor, they're not out of school, they're not disconnected from their family, and you help them get on a path, and the same medications that work 7 years later when they come to the attention of the system work then too, and they work better then because we're able to keep the person in school, help them get employed, help them not get alienated from their family, keep them in their community, and just like we would with other illness. And so 2,000 of them, and guess how much it costs to treat those folks for an entire episode of first psychosis treatment? $30,000 bucks, 2 years of $15,000 a year. Guess how much it costs to do a knee replacement or a knee surgery for somebody who blows their knee out playing football in Texas? About $15,000. So for 2 knee replacements, we can keep most of these young people on a totally different path. And the wonderful thing is that one part of our behavioral health strategic plan in our state is that under the leadership of Commissioner Gaines and her team, we have capacity, we're approaching the capacity, and the many partners in this room and our community centers across the state, we're approaching the capacity of serving almost half of these folks every year. This is exciting, folks. We could do this in Texas. We could get to where we treat all of those folks. And you know why we're going to max out at about 50% if we only fund this through Medicaid and state dollars? It's because half of them have insurance. Their moms and dads do. And if my son, and I've had many wealthy people in Dallas call me saying, hey, where do I send my son? He's 19, he has an early psychosis. I said, well, you can go to MetroCare. And they said, well, MetroCare, isn't that like take care of poor people? I'm like, yes, but they also have excellent other care, and they take care of people who are not poor. Well, I don't know if I want to send my son. I mean, you know, there's this idea like a public sector. So like we're doing great things with all of our community center partners to help people understand these are your specialty providers, folks. These are the community providers, and they take insurance. But insurance doesn't pay for early psychosis care right now. And that's something we're working with employers to change. And you know, we can do it because guess what? We get 16,000 new cases of breast cancer every year. And you know what? We want to treat them all. You know, we do. We actually keep track of how many women get breast cancer every year. We have a registry, and it's our goal to treat them all. It is not our goal today to treat every adult with a psychosis in Texas. And we can do that. And apparently the font got really big on the slide, but if you look down Texas with diabetes, that's what it says at the bottom. Guess how many Texans have diabetes? 2 million. 1.5 million Texans have depression. How many of you at your last appointment, because I see we have some people about my age out here, had a blood sugar test at your last doctor's appointment? All of you did, whether you know it or not. They test your blood sugar. You know why? Because they want to know if you have diabetes. That's why. I'm not going to ask rail of hands, but how many of you actually got a depression screen at your last medical appointment? I did, and it's changing. But if I'd asked you 2 years ago, very few of you would have. And a depression screen, by the way, is not, are you depressed? That's not a depression screen. That's like a dumb question that people ask. My doctor asked me if I was depressed. I said, are you kidding me? Like, you're not using the PHQ-2 to ask me? He goes, oh, no, I got the PHQ-2, but I figured since you're a psychologist, you would know. I'm like, no, I wouldn't know. I'm not allowed to diagnose myself. So the PHQ-2, which leads to PHQ-9, has an 80% chance of detecting your depression. You know what the chances are of that stupid cholesterol test I have to take every 6 months and argue with my doctor about? Like 60%, 50%. At one time, it actually used to be 50% before they came up with the new ratios, and so I'm kind of a smart aleck. And so my doctor said, I said, well, what's the chances that you're right that I have heart disease? Well, it's about a 50% chance. I'm like, so why didn't you flip a coin? You know, I mean, like, you know, because we would have had about the same reliability. So 80% chance of finding your depression. Do you know why most of you still don't get the PHQ-9? Because they don't want to know if you're depressed. They truly don't. The system is designed to not find out if you're depressed because they're worried they may not have enough doctors. That's a bad idea. Okay, we should know, even if we don't have enough doctors, because that's the only way we're going to get enough doctors. So let's look, same thing on substance use. We got about 1.8 million people with severe substance use disorders, many of which have co-occurring mental illness, as Dr. Natty talked about, but a lot of them don't. Fewer than we have in terms of diabetes. We even are less interested in treating substance use, both because many of us are functional and using substances on a fairly regular basis. Many of us are actually dysfunctional in this room using substances, and our doctors are not wanting to make us upset by asking us how much we drink. I had to add that up, especially because I go out to a lot of business dinners. It's scary if you start adding up how many opportunities you have to drink if you're in a position like mine where you eat out a lot and you're with people a lot and you want to be, you know, charming them and get them to donate money and all those other things you want to do. Alcohol does help with that. But a lot of these folks have illnesses, and just because you drink doesn't mean you have an addiction. An addiction or a severe substance use or a substance use disorder has to have functional impairment. So if all you're doing is getting people to donate more and they can afford it, that's not impairment. But if you are like fighting with your wife when you get home or staying out late or a bad dad, which maybe I am if I'm staying out that much, like hanging out with people, then that's something your doctor should be asking about. Lots of impacts from substance use. We heard about this earlier, but I just want to highlight a couple. 2/3 of people going into this child welfare system, the parents have substance use disorders. Leading cause of death for our maternal deaths, our big rising maternal death rate in Texas, opioids are driving that. And when people tell you that Texas doesn't have the same rate of opioid use, that big opioid death, that big blue line that kind of begins to come down like a mountain, you see both sides of the mountain, that is our prescription drug deaths, and those are coming down. They're not down to where they used to be, but they are coming down. We have put a lot of rules in place that make it harder to overprescribe. But look at that green line going up. That's heroin, folks. And guess what people do when you get them addicted to an opioid and then you don't let them get the prescription opioids after that? They replace. And it's not hard to get heroin. And we've been fortunate in Texas because we've had black tar heroin, which is hard to mix with fentanyl and some of the other things. We're starting to see more of the white powder heroin, which is easier to mix with fentanyl. And you can see that that other line that's creeping up is our fentanyl-related deaths, and that's going to go up. And this is 2015 data, and we all saw a big spike in 2016. So this is something you're going to see increasingly in your courts. And it begins in childhood. 2 million Texas children have a behavioral health condition. That's an upsetting number. It's approaching 40%. So people react to that in several ways. Sometimes people say, well, that must not be true. This is one of those, like, kumbaya mental health types that overstates the issue. I hope that I've demonstrated to you that I am not a kumbaya mental health type. Terry and I were talking about going hunting. I hunt. I understand how the world is. But the reason that number's so high is most of them aren't that severe. It's like little Andy, right, who was all anxious. And, little Andy was fine when his anxiety made him do better on tests, but little Andy wasn't fine when his anxiety made it hard for him to go outside and make friends and become as socially connected as we would have liked little Andy to be. So why couldn't Sue and Ray Keller have had their doctor ask them, hey, anything going wrong with little Andy? Well, Andy doesn't like to go outside all that much. Well, maybe Andy's worried about going outside. Let's talk to him. And a lot of times all you need is to give parents advice. It's harder to raise an anxious child. And a lot of times it's just parenting help. It's an illness, but it's something parents can manage a lot of the time with the right supports. But 370,000 of our children have pretty severe needs, and 20,000 of them, folks, are at such high rates of need that they're at risk of getting pushed out of home or out of school, and these are children in our child welfare system, our juvenile justice system, because just like with the adult system, we tend not to do anything until we're scared. So if we're scared the kid's going to die, or if we're scared the kid's going to be sexually abused more, or if we're scared the kid's going to commit a crime, then we'll do something. And we're not unlike a lot of other states. So being able to do something for them, being able to do more for youth with serious psychosis, and being able to do more for youth with suicide. We only lost 150 youth last year to suicide. I say only, ironically, because any youth that dies is a terrible tragedy. And if you look at those numbers, which I've looked at them more recently because one of my board members made me read that iGen book. Justice O'Neill, in addition to organizing judicial commissions, she also helps her CEO stay abreast of the latest research. But that iGen book really, I think, puts together, along with, or maybe if you look at CDC numbers, we have a serious youth suicide problem, folks, particularly in our rural counties. And the rates are going up. And there's something happening with our younger generation, and we need to be providing answers and helping with that, and school is a great place to do that. So I lay all that out, and this is kind of an answer to the woman's question about recovery, because there are different recovery paths for every one of these folks. And remember the thing that you're going to get A on the test on when you leave? If you intervene earlier and you treat it like other health conditions, then it's going to work out better. That's the path to recovery that works out best. ACEs are important. We do need to have trauma-informed care. And remember, ACEs drive illness. They don't drive mental illness. They do drive mental illness, but they drive illness. They drive heart disease. They drive life choices around alcohol. That really aren't choices. Life pressures around alcohol, substance use, other things. And these conditions add up. And this is really the new frontier. This is going to take more resources per the resource question. We're going to have to embed more resources in our primary care system. There's some legislation that Senator Nelson's announced she's going to file next session to fund a child psychiatry access network that's going to support primary care providers. This is something that almost 30 other states have done. It's been shown that it can help primary care providers have the confidence and skills and decision-making support to give kids the right medication and to not give medication when they don't need to, because that's the other thing. If all you have is medication and that's all you think you got, you over-medicate. And we see that in our child welfare system. We see that with youth who are concerning to us, which we know disproportionately impacts youth of color, because if one of my children who is white and one of my children who is African American, if I had an African American child, exact same situation, exact same behavior, my African American child would be 4 times more likely to be diagnosed or kicked out of school or something else related to my white child. So these are there's racial disproportionalities in there, but all of us have ACEs. And so helping primary care doctors do a better job identifying and treating ACEs is something that's going to help us. The other thing we need to think about is post-Harvey mental health needs. Hurricanes and the trauma that go with them are a major adverse childhood experience. And they are one that repeats over time. If children move, parents divorce, they lose their jobs, they escalate over time, and they take up to 4 years for all of the impacts to unfold. So we're 1 year in now. We're seeing the things we thought we would see. We know we're going to see more, but people are out there building supports, and that's exciting. And it's something to work on, and it's something you're going to hear about this legislative session. It's going to be tied to school safety more generally because of Santa Fe. And that's something that hopefully we bring a sober perspective to say, yeah, we do need to pay attention to mental illness in schools. And yes, there are a subset of young people who are driven by severe psychiatric conditions and end up hurting other people. But most likely they're going to hurt themselves or someone close to them. These extreme events where we get like what happened at Santa Fe, they're pretty rare. And the only way to treat that needle in the haystack is to treat the whole haystack. You can't find the needle. You're going to have to treat all of them and help them all. And that's okay. Let's help all of our children. But let's not stigmatize them, and let's make sure their parents are involved. So this is what the ideal system looks like. Notice it looks just like the health system because it is a health system. So we go to the primary care doctor, that cool integrated primary care green box there, and we get things like Vital Signs 6, which UT Southwestern has developed as a screen for all mental health needs that either a child or an adult might have. And guess what? It takes the doctor no extra time to do the screen. You do it in the waiting room, because the questions are very straightforward. In fact, there's higher reliability when people do these questions, assuming they can read, which not everybody can, but most people can, in the waiting room because they feel more confidential and they're more honest in those settings. And it also works great over telehealth. Telehealth psychiatry, equal or better effectiveness than psychiatry face-to-face. And think about what people are willing to write online. People are willing to say all sorts of things online. There's that lower barrier to disclosing that often happens. 2/3 of mental health needs could be treated among children and 3/4 among adults in primary care. So I want you to have more hospital beds, but I also want you to be talking to your primary care doctors, who are probably some of your friends, about are they screening in pediatric settings? Are they going to use this new child psychiatric access network that Senator Nelson hopefully gets in place next session? She's pretty good at getting her things through, being on that finance committee and all. And then are you working with your partners in the rehabilitative sphere, which are our community centers? They are our bulwark, our infrastructure to provide those things, and they're doing really cool things. One of my favorite things in the last year was Integral Care in Austin, partnered with the Dell Medical School to open a joint clinic for bipolar disorder. So everyone in that community, whether they're in poverty or whether they got insurance or whether they're the son of a faculty member, can go to the Dell Medical School, this brand spanking new clinic. They go right past the waiting room into their room, and they have physicians from Integral Care working alongside physicians from Dell because they're working together, and they provide treatment to everybody in that community. And that's what we need to do, folks. And you know what? It's not rocket science. It's collaboration, it's working on these things, and it's building this new system together. And I'm going to pause there. We're still a little bit ahead, but anybody questions in the last 5 minutes we have, or comments? And I mean, including like, yeah, Andy, you're like told some funny anecdotes and you showed funny pictures of yourself when you were a child, but I really am not sold on this, or I'm worried about this, or this part concerns me, because you should be concerned. I know you're concerned. But are there other things you kind of want to get on the table? Yes, sir. Yeah. 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 Okay, so I'm going to paraphrase just so folks can hear, and just shake your head if I get it wrong or nod if I get it right. So what he's talking about is the tension, right? And I'm going to frame it a little differently. But I mean, because you have a really severe concern about when you're interacting with your local mental health authority as a law enforcement officer about that interaction. Because you'll say that, hey, when you talk to the mental health authority, they knew this person, they know this person. They saw them earlier in the day, they knew they were having something, but they didn't do whatever they didn't do whatever it would have taken to keep that person from presenting in front of you as a law enforcement officer. And when you do try to get their help, then, well, they have to assess again, and there's hoops you got to jump through, and you spend a lot of extra time going back and forth with them, and then you may just see the person again. Like, there may not be ongoing treatment. Is that a fair paraphrase? Did I miss anything major? All right. So you're right. But I guess what I want to say is it's not we could put all the resources we could find. We could keep spending more and more through local mental health authority, and we're not going to solve the problem by getting the mental health authority to do more. What we're going to do, what we need to do is we need to break down some historical silos. And let me tell you about a couple of those. One of them is the silo between you as a peace officer and paramedics. Because if you have a baby that you have to deliver, I promise you're going to call a paramedic who's going to come help. You may do it if it's right then and there, like I almost had to do when we were driving down from the mountains in Colorado with my wife, and I explained to her, I'm not a real doctor, I don't know what to do, please wait. But we got to a paramedic, and the paramedic took us down, and when she saw the paramedic was maybe 18, maybe 19, she said, we're going to wait more, and we got to the hospital, and he was delivered 5 minutes later. So there's a whole bunch of other people that in other health conditions help you out. And we have set up this separate but equal, and I use that term specifically because it's always been a bad idea to do this, mental health system, where we say, hey, let's have a crisis response. Let's build crisis response to our mental health system. No, let's embed mental health crisis capacity from our local mental health authority in our crisis response system, working with our paramedics, so we're all working together, and with our hospitals, because right now we have silos around the police, silos around the paramedics, silos around the local mental health authority, silos around the hospital, and everybody's got to do their own assessment, figure it out themselves, because that's how we design the system. It is not any actor's fault that they're acting the way the system was designed. We have to redesign these systems locally. And I know that's an easy thing for me to say, but you can do it. We can do it. You probably can't do it on your own, but you and your partners can do that. And when you are working on these things together, sharing resources, which I'll tell you, we worked in one county. I mean, these feelings get big. In one county, deputies were threatening to arrest the crisis workers from the local mental health authority because they were so mad at them. I mean, seriously, I'm going to arrest you if you do not come out and respond. And I understand that, right? Because we all feel like the system is broken. Those mental health authority people aren't doing their job. Nope, they're doing their job. They're supposed to do those other assessments, but the job was designed 10, 20, 50 years ago. That hospital system was designed 180 years ago. We need to design things differently, and the only way we're going to do that is through your local leadership, working in partnership with your local mental health authority. And we got to kind of put those feelings aside and figure out some new ways to do things, and then figure out what the barriers are that we need the legislature and others to put in place. So, and I know that sounds easy, but it's not, and that's where we need to go. Yes, sir, and then there's a question over here, and then we'll stop because we don't want to get behind. Yes, sir. Yeah. Oh, he's right. So the question was, a lot of times people, when they have a health condition, they do want treatment, and a lot of times people you're dealing with, especially in the court system, don't want treatment. Absolutely true. By the time someone gets to your court, they're very much more likely to be refusing treatment than others. But don't generalize from that. I mean, you probably get more people who steal in your court and more people who abuse children in your court because of the court you have. That's who comes to court. That's not mental illness. And the reason that person is coming to court in that stage is because it's been 7 years since their symptoms started, and no one told them it was a mental illness. No one told me that anxiety was a mental illness I could get help with until I was 24 years old. okay? So we got to tell people, and parents don't know, psychologists don't know when their kids have mental illness. We are just as good as any other parent at pretending our kid is like a delightful, healthy child, even though he won't leave his room. So that's where we got to start. We got to define these things early, because by the time they get to your court, that's true. But I'll tell you, you probably didn't know my grandma. My grandma was not big on getting treatment, and I am not big on getting heart treatment. I mean, you can talk to my cardio specialist. I literally refuse to have the treatment because, like, I don't want to take those medications. He said, when are you going to start, though, taking this medication, do you think? I said, I don't know, when I'm old and I've given up and I'm taking other medication. I mean, so not everyone participates in treatment. It's actually a sign of health, but in your court, you're getting a disproportionate number of people who are psychotic, who are homeless, who are in a horrible situation, and we do need assertive treatment for them. And if you have assertive treatment, then you're going to be able to give them this treatment they need. And I think we just need to build the other services so you've got them. That's what I would say. And then one last question over here. Ma'am, you had your hand up. Go ahead. Yep. Absolutely. So the point was, and this is my last point I'm going to make, the history we have of not giving people treatment until they get to jail or the hospital is actually itself a barrier to care. And this is true. If you talk to people who are in recovery, who've had mental illness for a while, there's very few times in their life that have been scarier than when they've been arrested, they've been taken to jail, or they've been taken to a hospital. You know what? A lot of times, folks, it's not all that different going to the hospital because you're handcuffed, you feel incarcerated, you're in a locked unit. And this idea that we had in the 1850s of putting people in psychiatric hospitals, we still need to do sometimes. But if we wait till then and your first experience of treatment is being tackled and thrown in a police car and traumatized and taken to care, guess what? You're not going to be really thrilled about seeking treatment, okay? So if we wait that long, we kind of set ourselves up to traumatize people more and to create more barriers to care. So that doesn't mean you shouldn't send people to hospitals now. You should. I mean, we do need to do that. We need to do that more. But you got to think beyond not just the bench, but beyond the hospital. We got to get our systems acting different so that you don't have traumatized, multiply traumatized people showing up in your court as often 2 years from now as you do now, and maybe 10 years from now, it's a rare event. And we can do that. It is not a technology issue. It is somewhat a funding issue, but mostly we have to want to do it. And that's what it starts with. So if all you do is you go home and you are an advocate in your community for, we actually want to treat these illnesses, you are going to be a big help in changing this. I want to thank you all for being here. I want to thank you for the work you've done. And please use the rest of this conference to work with your colleagues and the other people in your community to figure out some ways to translate this into reality. Thanks.